Welcome to The Spine Guy. I'm Dr. Brian Sue, a fellowship-trained spine surgeon. The Spine Guy is a channel dedicated to making the complex spine simple for patients to understand. Today we'll be talking about one of the most commonly missed causes of low back pain, which is pain from the sacroiliac joint or SI joint dysfunction. So first let's start with the anatomy. So here's a model of the entire spine. There's a neck, there's a thoracic spine, this is the lumbar spine, which is a low back. The lumbar spine is attached to this big bone. The base of the lumbar spine is called the sacrum. And this is your ilium or your hip bone. So you'll see here that there's a big joint or line between the sacrum and ilium, and where the sacrum and ilium meet is what we call the SI joint. The SI joint is a true joint. Each of those bony surfaces has cartilage, it has joint fluid, and has a capsule around it, just like your knee joint, your elbow joint, etc. Here's another model of the SI joint. So there's the sacrum, again there's the ilium or hip bone. This is the SI joint, and this one we've taken apart to show you. This is the sacral surface of the SI joint. So it's an upside down triangle. You can see it's a really big joint. It's one of the biggest joints in the body. And on the pelvic side, that white portion there is where it attaches to the sacrum. So that's the entire SI joint surface, really quite a big surface. Unlike other joints like the knee joint, which moves quite a bit, the SI joint is one of the most stable joints in the body. It really only moves just 1 or 2 degrees. And the reason that it's stable is because it has lots of these little craters, and if you look carefully, this is not a smooth joint surface. It may be covered with cartilage, but there's lots of these little wavy undulations that give that joint lots of stability. There's also a very thick joint capsule that goes around the joint, and there's a ton of ligaments that go around the SI joint, giving it even more stability. Now, interestingly, the SI joint is a little bit more flexible in females because of hormonal changes, and that's why women are more susceptible to SI joint dysfunction. 20% of patients with low back pain, in fact, have it from the SI joint. As I said, it's very, very commonly missed. Now, what does that sensation to the SI joint come from? The sensation to the joint comes from these little nerves coming out of the sacrum. These are called the lower sacral nerve roots, and they come and they supply the SI joint with sensation. There are 3 common causes of SI joint dysfunction. The first is arthritis, which as patients get older, there's loss of this cartilage, and there's loss of the cartilage, the bones start to rub on the bone, and that bone-on-bone pain can cause pain directly in the SI joint. More common, which is what I think we see the majority of the time, is injury to that soft tissue capsule or injury to some of the soft tissue ligaments that surround the SI joint. And lastly, there's autoimmune diseases. There are certain diseases like ankylosing spondylitis that can actually affect the SI joint. There are 3 common ways that people with SI joint dysfunction present. All of these typically involve some sort of shear force on the SI joint. So if again, this is the SI joint, there's a sacrum, there's the ilium. Shear force is anything that puts pressure this way on the spine. And torsion, which is twisting, is any force that puts pressure this way on the spine. So you can imagine that if you have something where you have a direct fall onto your butt, there can be shear force on the SI joint. You can imagine that if you're sitting and you're driving and there's direct impact from a car accident through the gas pedal, the SI joint can get stressed as the ilium is pushed up against the sacrum. Or if you're stepping and you misstep into a hole or down a strange stair, there can be sudden unexpected impact where you're not guarded, and that injures the SI joint. There can also be chronic repetitive trauma from torsion and shear injury. People that do things like figure skating where there's lots of impact can also affect the SI joint. And lastly, quite a few of the surgeries we do are lumbar fusions where we use rods, screws, and cages to stabilize the spine. You've seen that in my other videos. When you put rods, screws, and cages to stabilize the spine and you fuse to the sacrum, there is something that's called adjacent level disease that can occur, which is you've taken a little bit of load away from L4, 5, and 5-1 because you fused it. So that next adjacent level you're stressing is the SI joint, and that can commonly be a cause of pain of people who have had fusions up to S1. Patients who have SI joint dysfunction usually complain of pain directly over the SI joint. They commonly have pain with sitting, and sometimes I'll know patients have it because I'll walk in the room, instead of sitting straight up, they'll be sitting offloaded, and they'll be trying to offload their butt cheek off of the side that's painful because it's decreasing the shear stress on the SI joint. Sometimes people say they have difficulty doing hills or stairs. And interestingly, SI joint pain doesn't have to be only over the SI joint. SI joint pain can often radiate to the buttock, down the leg, sometimes even to the foot. and even to the groin area. And it kind of mimics sciatica. Sciatica is a pinched sciatic nerve. SI joint dysfunction is not really pinching the sciatic nerve, but the reason people can often get buttock and leg pain that's referred is because there is a nerve that comes down. The lumbar plexus and the L5 nerve in particular comes right down and it drapes over the SI joint. And the thought is that there's some inflammatory mediators that can irritate the nerve as that nerve is going by. We do get imaging just as part of the routine workup, but x-rays really are not that helpful for looking at SI joint dysfunction. And MRI also, the MRI can visualize the joint, but the MRI is not fine enough to really look at fine tears around the joint capsule. We use an MRI to rule out the other things that can also cause low back pain that can mimic SI joint dysfunction, like disc degeneration, sometimes fracture, sometimes a pinched nerve, etc. Sometimes we can get a CT scan. The CT scan looks at bony anatomy, but again, the CT scan is really not that useful. I'm not routinely ordering a CT scan in people that complain with SI joint pain. Physical exam is really the best way to diagnose SI joint pain, and the physical exam really involves feeling around the SI joint to see if people have point tenderness. I always tell patients, does it hurt with a finger spot or does it hurt where the palm is? Because if it's a palm, usually it's not the SI joint. SI joint pain is usually point tenderness over the SI joint. So what I'll typically do is I'll feel for the patient's iliac crest, and that's usually on the side, and I'll trace it down. You'll feel this big bump here. This big bump is called the posterior superior iliac spine, or PSIS, and if you drop right towards the spine, towards the midline, that little divot right there is the SI joint. So people that have SI joint dysfunction have pain directly over that SI joint. Sometimes this big bump can be hard to feel, particularly in people that are a little bit bigger, but you can almost always feel this little ridge and just drop right inside, and that's where patients usually complain of SI joint pain. There's lots of tests that a spine doctor might do, and you'll probably see these tests on the physical exam note, things like the thigh thrust, the Ganslins, the Faber, etc. There are two tests that are really the best, they're the most sensitive, and lucky for you guys, they're the easiest to do at home. One is called a Fortin finger test, the other one is called a thigh thrust test. The Fortin finger sign is when you ask the patient to point to where they have pain, they take a finger and they point directly to the SI joint. So that's a positive Fortin finger test. I know what you're thinking, it's kind of insane that a doctor actually got that test named after him. The thigh thrust test is a test that we perform with a patient flat, usually on a firm surface. You can either do it on carpet or on a firm bed, but it's basically to replicate shear force. So we take a patient, we flex their hip up 90 degrees, their knee 90 degrees, and downward pressure is placed like that in order to push the ilium down and to shear the SI joint and to put pressure on the SI joint. A positive thigh thrust test when people have pain while we're pushing directly down onto the knee against the bed and they have pain over the SI joint. Really the best test for SI joint dysfunction is still an SI joint injection. An SI joint injection is exactly what it sounds like. So it's a diagnostic injection where there's local anesthetic or numbing medicine in a needle, and that needle is placed into the SI joint and the entire joint is numbed. This is usually done under x-ray guidance, sometimes by a physiatrist, sometimes by an anesthesia pain person. This can be done at the surgery center, this can be done in the office, but essentially a positive test is when you have at least 75% reduction in your pain after the injection for the life of the anesthetic. Now that can be sometimes 2 hours, sometimes 6 hours, but the pain obviously comes back when the anesthetic wears off. It's really important to understand that in order for this test to really be useful, you need to be in pain before you're given the injection, because if you're not in pain before you're given the injection, then you won't know if the injection helped. Or you have to be able to elicit the pain or generate the pain after you get the injection. So for example, even if you're not in pain, but you know if I go for a 1 mile run, my SI joint's gonna hurt, you come in, you have the injection, the anesthetic is put into the SI joint, then you go for your 1 mile run and see if you still have SI joint pain. If you have 75% reduction in that pain after the injection, then that's a positive test. Now sometimes the anesthesia pain docs and the physiatrists, inside the syringe, not only will there be numbing medicine, there'll also be a little bit of steroid. Steroid, which is cortisone, is a very strong anti-inflammatory. The upside of that is if the pain is coming from the SI joint, you put anti-inflammatory in the SI joint, that relief may be longer lasting than just the anesthetic medicine. The downside is anytime there's cortisone or steroid placed anywhere in the body, some of it does get absorbed in your body and it makes everything feel better. So even if the problem wasn't the SI joint, you may still get relief. So it does lose some of those diagnostic properties. Thanks for watching. Hopefully you understood a little bit about what causes SI joint pain, how to diagnose it. In our next videos, we'll be talking about some of the non-surgical and surgical ways to treat SI joint dysfunction.